Ladies and gentlemen, we want to get started now. Our speaker for today is Dr. Howard M. Druce, who comes from our mother country, England, originally, and is a member of the Royal College of Physicians by merit rather than by having the honor conferred on him, and is presently engaged in clinical and research activities associated with St. Louis University in the field particularly of allergy and asthma. His topic today will be devoted rather than to allergy to the subject of asthma and some of the newer concepts that are emerging as far as the therapy goes, and probably review the etiology for you. He has a very comprehensive curricula vitae, but I'm certainly we have a very well qualified, and we're going to have a informative speaker today, Dr. Druce.
Thank you. What I'm going to do today is go over a lot of material, probably fairly rapidly, to give you a wide overview of some of the current excitement in asthma. And I think that it's quite appropriate to look at asthma again, because there is a tremendous amount of new knowledge both in terms of the pathophysiology of asthma and in terms of new therapy, and also looking at some old therapy in new ways to treat this disease much better than we're doing previously. So if we can just have the first slide, and then we'll get started. Okay, so first of all, this is all familiar to you. This is St. Louis, and greetings from St. Louis University. Now, first of all, let's start off with a definition. What do we mean by asthma? And it's been very difficult to agree on definitions, but basically here are two commonly accepted ones: the presence of widespread narrowing of the airways, which alters in severity either spontaneously or in response to treatment, or increased responsiveness of the trachea and bronchi to various stimuli. Now, you note that this does not necessarily conform to the definition of reversible bronchospasm, because it's not always bronchospasm that produces the pathology, as we've come to understand. And here is the differential diagnosis of asthma. I'm not going to go into this in a lot of detail, but it makes the point that all that wheezes is not asthma. And patients can have wheezing from cardiac disease, from bronchiectasis, from contact with inhaled allergens, and have a hypersensitivity reaction. And just as an example of this, I have a patient who has severe bronchospasm, severe wheezing, whenever he comes into contact with cleaning fluid. And this is not an allergic reaction to the cleaning fluid, but it's probably a hypersensitivity reaction. Other things that we think of in the differential diagnosis: irritants, pulmonary embolism, aspiration. It's a well-known differential list. In terms of our understanding, we now know that it's not just allergic disease that is the component of asthma, nor is it simply bronchospasm. Now, in the acute form of asthma, certainly bronchospasm and stimulation of the muscle is very important. However, in chronic asthma, we understand that it's a damage to the epithelium that leads to genesis of a lot of symptoms. And because of this, we are paying more attention to the neural connections of the airway, as well as the neural connections to the muscle. And we know that the cholinergic, or rather the adrenergic system, plays a very important role in modulating bronchoconstriction. But the presence of other neurotransmitters, such as vasoactive intestinal peptide, some of the other neuropeptides, are perhaps just as important. And although I'm not going to present the evidence for it today, in addition to adrenergic control and cholinergic control, we understand a third system of non-adrenergic, non-cholinergic control, which again is important, because if you treat these patients with beta agonists, with cholinergic antagonists, you still are going to develop symptoms, and this is perhaps due to activation of the non-adrenergic, non-cholinergic nervous system. So again, although we know that there's a wide differential diagnosis, again, there's a lot of different pathways by which the pathology can be generated. And so infections, inhalants, irritants, foods, a lot of other triggers, exercise, polyps, a lot of things can trigger asthma because there are many points in that scheme that can generate symptoms. Either you can have direct damage to the airway, or you can have stimulation of the neural reflexes, you can have central stimulation. All these can generate the symptoms of asthma. And so probably in any patient with asthma, we're not looking at one pathologic pathway. Because there are so many different factors that generate that pathology, we consider that the term bronchial hyperreactivity is fundamental to the pathogenesis. Now, what do we mean by bronchial hyperreactivity? What we mean is that the airway reacts abnormally to a stimulus than compared to a normal person. And that can be either in terms of bronchospasm or in terms of glandular secretion. And hyperreactivity is ubiquitous in patients with asthma. What that means is that even if a patient is asymptomatic, they will have a level of hyperreactivity, or the hyperreactivity will be present. And that's why the methacholine challenge test is useful in patients either with mild symptoms or atypical symptoms, such as chronic cough. The degree of the hyperreactivity correlates with the clinical degree of asthma. So somebody who has a severe asthmatic state will produce an increased reaction on the methacholine challenge. And also accounts for facts that anything that increases bronchial activity will precipitate or worsen asthma. So the viral infections, air pollution perhaps with or without ozone, will increase asthma due to a non-specific or non-allergic sensitization. And this is why patients who are subject to precipitation by weather changes, by dusts and irritant chemicals are not necessarily allergic, and by allergic we mean through an IgE-mediated mechanism. They're not allergic subjects, but they still behave as though they have allergic symptoms because they have this bronchial reactivity. And central to the pathogenesis of bronchial hyperreactivity is this cell, and this is a mast cell, and as you can see it has a lot of granules in the mast cell which on stimulation either by antigen or by non-immunologic means produces release of those mediators and causes some of the symptoms of asthma. And the way it works is as follows, and this is the overall scheme by which these cells work. And here you can see these are just two phases, and the next two will appear on the next slide. But here, I think this may focus a little better at the top, you can see that an allergen, first of all, encounters T lymphocytes. These are the memory cells which stimulate the B lymphocytes to change into plasma cells, to differentiate into plasma cells, and the plasma cells produce specific IgE. The IgE then comes along and sits on IgE receptors on the mast cell. This is a mast cell. And when two IgE molecules are present, they cross-react these receptors and the mediators are released from the granules. However, this only occurs when there's a second exposure to an allergen, and also occurs only, this is the IgE-mediated mechanism. These granules can be released also by non-immunologic means. They produce a number of mediators which produce symptoms of allergy. Some are vasoactive, for example, histamine, prostaglandins, kinins, and leukotrienes. And others recruit other cells into the area. This is eosinophil chemotactic factor, neutrophil chemotactic factor. And these vasoactive mediators tend to be released immediately and produce immediate effects. So, for example, histamine and the leukotrienes cause bronchospasm. The other cells, the other factors, although they're released immediately, cause a slower accumulation of cells, and these cells, eosinophils and neutrophils, produce inflammation. And another term for the inflammation is the late phase of asthma. And so the late phase of asthma pathologically is inflammation. So it's not surprising that if we consider the late phase reaction to be the cornerstone of chronic asthma, then anti-inflammatory drugs, principally steroids, are going to be important in the treatment of chronic asthma. And so here's a mast cell. It's stimulated, the mediators are released, and we have a classic allergic reaction within minutes. Now, depending on the organ affected, we get all the symptoms which are produced by that release. So if, let's say, the mast cells were in the nose, we would get a production of secretion, we get fluid, we get itching, irritation, sneezing, tickling. If the mast cell is in the skin, we get formation of hives and the patient has urticaria. If the mast cells are in the lung, we get predominantly smooth muscle contraction, but also vascular leakage, and that we call asthma. However, if the patient gets a severe insult and mast cells throughout the body are affected, we get, in addition, flushing, hypotension, mucus secretion, and we call this anaphylaxis. So the effects of this depend where the mast cell is located. Now, the late phase reaction occurs 2 to 8 hours later than the stimulation. We get eosinophils and neutrophils coming in, and later an infiltration with mononuclears, macrophages, and the like, and that is the so-called late phase or an inflammatory reaction. Again, we get an allergic reaction, we get a late reaction, and this feeds into this, causing this bronchial reactivity. And because we get this non-allergic bronchial reactivity, that's why we get when we get exposure to non-allergic stimuli such as irritants and exercise, again we get genesis of symptoms. In terms of pathology, the early phase reaction consists mainly of bronchospasm, but in the late reaction, because cells are infiltrating into the lining of the bronchi, and in the later phase there's a full-blown inflammation, it's not surprising that bronchodilators are ineffective in late sustained asthma, whereas in the rapid or the early phase of asthma, then they can be quite effective. Now, how does this affect airway function? And here you can see an allergen stimulation, an immediate allergen stimulation, and a control inhalation. The control has no effect on the FEV1. However, when the allergen is put in, first of all, we get, actually this is the wrong way around, this should be a fall well actually that's right, there's an initial fall, and then it comes back to normal, but then there's a secondary fall in the FEV1. What they're not showing you here is that actually this should start off as 0, and after the allergen it dips down to this low level, goes back to normal, and we get the so-called dual or late phase reaction. And this occurs in about 10% of subjects, and it occurs relative to the dose. So the larger the dose of the antigen, the more likelihood of developing this late phase reaction. How do we recognize this reversible airway disease? Obviously, there needs to be a clear history of asthma with wheezing and shortness of breath. We need to demonstrate this, and as you saw in the last slide, there was a change in the FEV1, and this always is not manifest in terms of wheezing. Often we get a recurrent cough, and that can occur. As I mentioned, there's hyperreactivity, which accounts for a positive response to a challenge with methacholine or histamine, and then improvement after a trial of what's termed intensive therapy, and I'm going to talk about that a little bit more. Now, if you accept that hyperreactivity is generated, first of all, by an allergen causing the reaction, and secondly, producing some degree of inflammation, then it's not surprising that the beta agonists, which are used to treat bronchospasm, are not going to be the sole answer to treating asthma. And this slide compares the effects of the beta agonists and steroids on changing bronchial hyperreactivity. And here you can see the dual reaction in terms of FEV1 and the effects of a beta agonist and the effects of steroid. The beta agonists really don't have any effect here in terms of affecting the late reaction, and in fact if you measure bronchial hyperreactivity, they have no effect on bronchial hyperreactivity. If you look at corticosteroids, they have no effect on the immediate reaction but do reverse the bronchial hyperreactivity. And this is a clue to the fact that steroids will in fact prevent the late phase reaction. Now, in addition to that, you've already seen that mast cells and antigen are involved in generating the asthmatic reaction. And the next two slides look at the effects of antihistamines on asthma and on bronchospasm. And in the past, it's always been considered that antihistamines are not indicated for asthma because they might have drying effects. Well, now that we're able to study the novel antihistamines, which are pure H1 antagonists and have no anticholinergic drying effects, larger doses have been able to be used, and so their effects on asthma have been looked at. And this shows the change in FEV1 after placebo and after different doses of terfenadine. And here you see 60, 120 and 180 milligrams of terfenadine. And what this shows is that there is a slight but sustained increase in the FEV1 after prescription of an antihistamine, administration of an antihistamine. And that's sustained for up to over 3 hours after dosing. What this is saying is not that antihistamines are indicated as sole therapy for bronchospasm. However, if somebody is getting some sort of a challenge, and whether that challenge is antigen or exercise, it would not be illogical to give these people an antihistamine because they do have a mild bronchodilator effect. And certainly during the allergy season, one should not withhold a non-sedating antihistamine. Those, in fact, were normal patients who had exercise-induced symptoms. And here we can, this is bronchoconstriction induced by AMP, so this is in the laboratory, and the effects of antagonizing that bronchoconstriction by two different non-sedating antihistamines. And you can see in the open triangles here the effects of astemazole, and in the circles the effects of terfenadine. And here we're talking about 120 milligrams of terfenadine or 2 Seldane tablets. And again, compared to placebo, you can see that certainly here there is an improvement in the FEV1. You don't see the fall in FEV1 that you do with placebo. So again, at least in the initial stages, it would be useful to give a non-sedating antihistamine to prevent this form of bronchoconstriction. Of course, there are differences between the non-sedating antihistamines and the classical ones. When we look at the classical antihistamines, we're very concerned because of their anticholinergic activity. And of course, the question will come later is that of any value in the treatment of asthma? But certainly in terms of drying effect, it's always been the worry that antihistamines would dry the mucus and perhaps cause plugging. Even with the classical antihistamines, that's never clearly been shown to be the case. Depending on the antihistamine, the sedative activity does vary, and that is dose dependent in some agents, but clearly not all agents are alike, although they have all been considered to have the same antihistaminic activity. The other point I want to make is that they do have different activity on other receptors, and this may be important in terms of asthma. It may not be important in terms of treating rhinitis, although we're not sure of that at the moment. The duration of these medications does vary, and again it varies from a few hours up to several hours and several days. There's some question of whether these in fact probably do act a lot longer, certainly up to, I would think clinically, up to 12 hours, certainly in rhinitis. But the point I want to make here is that when we start looking at these agents, we've been finding that they have other effects. And if you look at this one, here at cetirizine and loratadine, they have mild anti-inflammatory effects, which again may be of value in asthma. Although not presented on this slide, tafenidine has an activity at stabilizing mast cells and preventing mast cell mediator release. And that is when it's given in a dose of 120 milligrams. So again, that may be another potent reason for considering the use of one of these agents in asthma. Not only is the time of peak action varied, but also the half-life. And I want to make the point here is that if you are going to give a non-sedating antihistamine, it suppresses the wheel on skin testing, and so we cannot do allergy skin testing on these patients unless the antihistamine has been withheld for an appropriate duration of time. For tafenidine, we like to have people off this for 2 to 3 days, but for astemizole, we've seen patients who have been on this agent and had their skin tests suppressed for 3 or 4 months. In fact, we have a patient in the office earlier this morning who came in having had negative skin tests for 5 months, and we've been testing him at monthly intervals because we can't do the skin test until the histamine control returns to normal. Now let's talk about some classical and non-classical ways of treating asthma. And 200, at least in the Soviet Union, this was one of the ways of treating asthma, and that's putting somebody in a salt mine 200 meters underground. Well, I think in the current era, at least even in the Soviet Union, that's not the best therapy for treating asthma. And these new concepts of asthma have led to novel forms of treatment. Because we understand chronic asthma as an inflammatory disease, some people have even tried to coin a more descriptive name for it, and one term is desquamative eosinophilic pneumonitis. Now that's a big mouthful, but it tells you what's going on, because in patients who have asthma, even the mild forms, there is an infiltration of eosinophils into the lining of the bronchi, and these can be recovered on bronchoalveolar lavage. There is a desquamation of the epithelium, which leads to exposure of the irritant receptors, and it is a pneumonitis because there is inflammation. The evidence for inflammation, even in mild asthma, is based on some studies that were reported in the New England Journal. They took mild asthmatics and did lavage on these subjects and were able to recover a lot of epithelial cells in the lavage, mainly neutrophils. So again, these were patients who are not atopic, again leading to our impression that there is chronic inflammation even in mild disease. What does this mean in terms of therapy? It's led to a lot of patients being treated now with steroids, and principally the inhaled steroids, as first-line therapy rather than just bronchodilators, because the bronchodilators reverse the symptoms on a temporary basis but do not attack the underlying pathology. This is a scheme of where the beta agonists and where the steroids come in terms of treatment, and the mast cell certainly leads to bronchoconstriction. The beta agonists will have an effect at eliminating bronchoconstriction. The steroids work at a later stage, but will inhibit the eosinophils from coming in and generating the late phase reaction, and also attack the macrophages here. So again, what we're saying is that the steroids don't work at the early stages where bronchoconstriction is generated, but work at a later phase and prevent this inflammation, and the inflammation which goes on to generate bronchial hyperresponsiveness. Now, where does cromolyn fit into this? And cromolyn has been advocated as a prophylactic agent in asthma. If you take a provocative challenge here at time 0 and look at the effects of cromolyn and prednisone, this actually is prednisolone, but as you know, in the body, prednisone has to be converted to prednisolone before it's active. After this challenge, patient is pre-treated with prednisolone, still has an early reaction, but does not have a late reaction. Cromolyn prevents both the early and the late reaction. So theoretically, it would be, on this basis, you would want to treat your patient with cromolyn rather than with prednisone if your object is to prevent the late phase and the early phase reaction in asthma. And here again, with cromolyn, this action is not just an immediate reaction, because as you can see here, up to 56 weeks of treatment compared to placebo treatment, the severity of asthma is improved with chronic cromolyn treatment, again suggesting that this is based on prevention of a chronic reaction or chronic inflammation. I'm not suggesting that cromolyn is an anti-inflammatory agent, but in some way it's preventing this late phase reaction. Now, if we look at a different aspect of this in terms of treatment of asthma, not only do we want to prevent genesis of a late phase reaction, but we want to prevent many of the triggers which set up the asthmatic state. Infections, principally viral infections, can cause or make asthma worse. Sinusitis can make asthma worse. Gastroesophageal reflux. Allergy makes asthma worse, obviously by direct challenge, and also there's some very interesting reflexes which are set up in patients with allergic rhinitis. Cystic fibrosis, weather changes, and pollution. And obviously some of these we can change and some of them we can't. But let's talk a little bit about sinusitis and bronchial asthma, because the question has arisen, well, are these common diseases that coexist commonly, or does an exacerbation of sinusitis precipitate bronchial asthma? Well, in certain instances there's a syndrome which connects the two. And this is the so-called aspirin triad, or Samter's disease, which really isn't just a triad. Certainly patients who are sensitive to aspirin can have rhinitis and asthma. They also have nasal polyposis. What's often forgotten is that these patients with aspirin sensitivity frequently have a hyperplastic sinusitis, which has to be treated. This doesn't mean that all patients with polyp